So with that, I'm going to introduce Dr. Kevin Onofrey from Henry Ford Health to show you a couple of his cases. Kevin?
Gary, thanks so much, and thank you to the Sermonics team for having me. As one of the vascular surgeons of many that are out there, I do consider myself a little bit of a limb salvage warrior, and this device really kind of revolutionized what we were able to offer, and nothing really pointed that out than our maiden voyage. Next slide. First patient actually that this device was used on within the Henry Ford system was, this case ended up being a happy outcome, but an 83-year-old female. Medical history is significant for atrial fibrillation and chronic kidney disease. Next slide. She had presented, next slide, please. She had presented actually to an out-of-state hospital, and she came in with pretty typical ALI presentation with right foot pain, numbness, paresthesia, and cyanosis. At that institution, they had performed a CTA showing that she had an external iliac artery occlusion with evidence of distal embolization to her tibial vessels. First attempt at treatment for her was percutaneous aspiration thrombectomy with one of our go-tos, the penumbra lightning bolt. Post-procedurally, she had evidence of flow at the level, at least per report. I didn't see the angiogram, but per report, going into the posterior tibial along the medial malleolus. Unfortunately, at that hospital, 2 days later, again, she had reocclusion of her external iliac artery, and at that time period, there was no flow noted on examination. Next slide. At that time period, they do what oftentimes we do. We reassess things and go back to the drawing board. Ended up performing both cut downs at the level of the femoral artery as well as at the distal popliteal in the P3 segment, and performed open Fogarty thrombectomies. Again, at completion of that procedure, there was pulsatile flow at the level of the popliteal artery, and there was a monophasic signal at the posterior tibial distribution, again at the level of the medial malleolus. But as, again, within 24 to 36 hours later, there is progressive ischemic changes, and that signal was no longer present. At that time period, they thought that they had kind of taken her through the options that were available, and with her physical exam findings, she was offered a major limb amputation, a BKA. Her family, who had ties up in Michigan, elected to actually bring her up, and that's kind of where I got involved. Next slide. These are the typical presentations I think that a lot of us all dread when they're coming in and or with our patients or those that were treated elsewhere, but this is what her foot looked like on presentation. In order to reassess things, again, I got a CTA that showed that there is patency within the external iliac vasculature through the femoral vessels into the popliteal, but there's no runoff appreciated at all beyond the mid-calf, which is, again, I went in and spoke to her and said, well, there's not a lot more that we have available, but there is this new device that we had just gotten in. And next slide. Ended up taking her. Again, rather than go and do a percutaneous access, I elected to just reopen the groin incision from 2 days prior in order to circumvent any sort of issues with the contralateral leg. This was my first angiogram. You can see again here that really the tibial bifurcation was open. The peroneal was the dominant runoff. The AT kind of became diminutive. And looking down into the foot on screen right there, you can see that there is really a paucity of flow getting into really any aspect of the foot, with the exception of that little pedal vessel that was kind of coming back. Next slide. And so again, from the standpoint of the operation, I took a 7 French sheath through the SFA, parked it in the distal popliteal, and kind of looking at the anatomy, I was curious that the peroneal was the dominant runoff. So that was kind of the first target that ended up taking. And I was able to go through the communicating branch that went over to the posterior tibial and into the foot vessels, and successfully get a wire extending out into the arch. And at that time period, it was an 014 Command ES. At that standpoint, I was easily able to deliver the catheter cistern that came with the Pounce LP to that level. And I was able to proceed with 2 successful passes of the Pounce LP. Next slide. And you can see here that this large communicating branch, which was really serpiginous, there's a lot of different bends going out, but it was a significant vessel for sure. That ended up again filling distally into the pedal vessel and kind of reconstituting the PT at the level of the medial malleolus, although you don't see the PT coming down from above. I then, was able to assess angiogram and see the contrast wash out at that level, and assess with Doppler, realizing that I had a low resistance Doppler signal that I was appreciating, again, showing that there was likely some success here. Next slide. I knew that there is no options with regards to the toes. Those clearly didn't have any flow, but next slide. This was at 4 weeks, continuing to allow demarcation. You can see on slide left, the plantar surface was completely salvaged. The dorsal surface of the foot continued to have healing. Next slide. I was able to successfully perform a TMA at week 9, and subsequently she completely healed that and continued to have pulsatile flow in the distribution. Next slide. Now, when we turn around and we talk about what we're looking for, the patient and her son, when she returned down to Florida, which is where she originally transferred in from, was very happy to be able to send this video that she was back up on the dance floor, which was one of her favorite things to do. And when you turn around and you go through your algorithm of ALI options that are available, certainly you're not done until you get a picture like this or a video like this from a patient showing that they are ambulating and successfully, able to, get on with their life. So after this was the maiden voyage, this was an opportunity that we all looked at this case and we thought that, the expected outcome was probably not limb salvage, but this device offered kind of a new option for us. Since then, many, not just myself, but many of my partners have turned to it as a primary device that we end up using, not just in, more organized clot, but certainly in acute thrombus as well too.